Hello again, everybody. We're going to talk here about the neurocognitive disorders. This has been renamed just very slightly from the DSM-4-TR to the DSM-5. We used to call these cognitive disorders. Now we call them neurocognitive disorders. So really not much of a difference there. So the major changes is that we have collapsed the diagnoses of dementia and amnestic disorder. They used to be separate diagnoses. Now they are subsumed under the newly named entity major or mild neurocognitive disorder, NCD. You have to know what disorder the neurocognitive disorder is attributed to. If you need to specify that if it's known. And that's really just because neurocognitive disorder is more of a symptom rather than a diagnosis. So you need to specify whether this is due to Lewy body dementia or Alzheimer's or Pick disease, etc. And we're going to talk about these individual diagnoses, and really that's more important for the test and also kind of for practice too, that you pin down what the cause is behind the neurocognitive disorder. The neurocognitive disorder will be a manifestation, but it's really the cause that you want to know, because the way we treat Lewy body dementia can differ from the way we treat Huntington's disease, differs from the way we treat Alzheimer's, and so forth. The term dementia, even though it is not a specific diagnosis itself, is still an appropriate term to use in the realm of the etiological subtypes where that term is standard. So, for instance, it is perfectly appropriate to still refer to it as Alzheimer's dementia, even though we no longer diagnose dementia per se, we diagnose it as neurocognitive disorder. So a major neurocognitive disorder needs to fit the following criteria. So evidence of significant cognitive decline from a previous level of performance in one or more of the cognitive domains: complex attention, executive function, learning and memory, language, perceptual motor, or social cognition. And this is the same criteria we used to diagnose dementia. You needed to be lacking in performance in at least one of these domains. And this is based on concern of the individual, concern of a family member, typically this is a knowledgeable informant, or your own concern, particularly if you've had prolonged interaction with this patient and you've noticed a significant decline in cognitive function. There also needs to be a substantial impairment in cognitive performance, and we prefer to have this documented by some kind of standardized neuropsychological testing. A good way to get an objective idea of a patient, especially with dementia, is the mini mental status examination. Criterion B is cognitive deficits that interfere with independence in everyday activities. And really, this is going to be your best criterion to help you differentiate major neurocognitive disorder from mild neurocognitive disorder. And then C, the cognitive deficits don't occur exclusively in the context of delirium. So patients who have delirium may appear to be dementia or amnestic, but if it exclusively occurs within the context of delirium, it is not a neurocognitive disorder, it's delirium. However, it's important to remember that patients who have dementia or amnestic disorders that fall under this category of neurocognitive disorders, they certainly can have delirium at times. And then D, it's not better explained by another mental disorder. Particularly here we think of major depressive disorder. So remember that major depressive disorder oftentimes in the elderly can manifest as forgetfulness. And so that may make you think Alzheimer's when in fact the patient is simply depressed. And remember that the way we differentiate the two of these, a good way to differentiate the two of these, especially for test-taking purposes, is that the patient who is forgetful, that has depression, so an elderly patient with depression manifesting as forgetfulness, they will typically not care the fact that they're forgetful, and they'll just say, I don't know, I don't know, I don't know, when you ask them things. On the other hand, patients who have Alzheimer's will try to come up with, or other dementias, try to come up with an explanation. So you'll ask them, how did you get here? And they'll give you the reason or the way that they got there, but it will be incorrect. Mild neurocognitive disorder, basically the same criteria here. The only difference is the degree. So with mild neurocognitive disorder, it's evidence of a modest cognitive decline from a previous level of performance in one or more of the cognitive domains, and this is based on concern of the individual, knowledgeable informant, i.e. family member, or you as the clinician, that there's been a mild decline in cognitive function, and a modest impairment in cognitive performance, preferably by standard neuropsychologic testing. Most importantly, it's going to help you differentiate this from major NCD, is that the cognitive deficits do not interfere with independence and everyday activities. And then finally, we need to make sure that this is not occurring exclusively in the context of a delirium, and that it's not better explained by another mental disorder or the use of drugs, and so forth.
So some general principles of cognitive disorders. What are they? Cognitive disorders are disturbances in various cognitive and executive functions and or in memory. So what are these cognitive functions? Well, they're the ability to speak, the ability to execute motor skills, they're the ability to recognize objects, they're the ability to think abstractly and do things in daily life. So these are the things that are disturbed in these patients. And the process can be acute or it can be insidious. And that's really what's going to help us differentiate between dementia and delirium. So there's a myriad of causes. We're going to go over all of those causes, most of them. And what's most important is that you first differentiate delirium from dementia, and we're going to talk about that. And then at that point, then you're going to determine the cause. Amnesia is a little bit different from delirium and dementia. People with amnesia are generally able to recognize daily objects and they're able to speak and they have motor skills, but their problem is simply a loss of memory. So the two major types of cognitive disorders, the two major classes of cognitive disorders, are delirium and dementia. And the most prominent thing about delirium is that it's acute and reversible. So this isn't something that a patient's family member brings them in, and they've been having for 8 months. This is something that a patient will develop on the wards, or it's something that a patient will be brought in by law enforcement or a family member to the emergency department. So delirium can be caused by general medical conditions, or it can be caused by substance intoxication. Dementia, on the other hand, is chronic and generally it's irreversible. So this is something that's much more insidious. It's something that really people aren't going to realize until it gets to a certain point. So it just kind of sneaks up on people. Generally, these patients are going to be brought in by family members because most patients with dementia don't realize that they have dementia. There is one major exception, and we'll talk about that. Dementia processes are almost always irreversible. There is one major reversible type of dementia, which is pseudodementia. That's actually the only one we're going to talk about as far as reversible types of dementia. I did give the other possible reversible types of dementia. It's really up to you, though, to make sure that you exclude these, and most of these can be excluded by a basic history and physical. So on the USMLE, if there are any glaring abnormalities on the history and physical, you'll be given that. If the patient comes in and they're clearly intoxicated, then you'll be given that. If the patient has an endocrine abnormality, you'll generally be given that. If they have a tumor or trauma, you'll be given that. If they have a mass occupying lesion, if they're infected, you'll know because they'll have a fever or they'll have low blood pressure. So those are things that the USMLE should give you. So we're going to primarily be focusing on the irreversible types of dementia. And then amnesia, we'll talk about Wernicke-Korsakoff Syndrome. So let's start off with delirium. Delirium is a disorder characterized by an acute confusional state. So this is more something that hasn't been around for very long. It just sort of creeps up on it just sort of comes out of nowhere, and the patient is confused. That's what's most important, is that the patient is confused. They're going to appear confused. They're going to appear unable to do things that are necessary for themselves, and so usually they're going to be brought in by somebody if they're not in the hospital already. So as we mentioned, it's acute and reversible. Delirium is not a chronic state by definition. Delirium is also not a diagnosis. We don't diagnose people with delirium. Delirium is a syndrome, so it's a set of symptoms that coincide with each other. So there's multiple causes of delirium, and so delirium is not an actual diagnosis. It's a state of being. What is characterized in delirium is disorientation, memory impairment, and reduced attention. And you'll know this when you do the MMSE, the mini mental status examination, because the patient, most importantly, will not be aware of place, person, and time. And that doesn't happen with dementia. They don't just all of a sudden be disoriented to place, person, and time. Patients with delirium will have a decreased inability to concentrate, so they'll have a problem recalling objects from memory, and they'll have difficulty with the serial sevens. Circadian rhythm is often disrupted in patients with delirium, so a lot of them will be sleeping during the day and they'll be up at night. Delirium also waxes and wanes in its severity, and it's associated with many possible causes, so the history and physical is going to be very important for delirium, diagnosing the specific cause. So the predisposers for delirium is an old age. Older patients tend to be more susceptible to delirium than younger patients. Patients with psychiatric comorbidities, especially mood disorders, major depression, are going to be more susceptible to delirium. Sensory impairments, if you're blind or deaf, you're going to be more susceptible to delirium. And then patients with nutritional problems and drug intoxication dependence. And definitely keep an eye out for delirium on the surgery floor. A lot of the anesthetic agents that are administered during surgery are key precipitators of delirium. So some of the most common causes of deliriums, as mentioned before, drugs, and these can be illicit or administered drugs, so anticholinergics and benzodiazepines, surgically administered drugs, anesthetics, and opioids, so either the ones that you're given during surgery or heroin. Dehydration is also another cause of delirium. You're going to want to rule that out right away, because that's something that you can quickly correct. And then infection, specifically the CNS infections, so meningitis and encephalitis. The diagnosis for delirium is clinical. It's definitely necessary to rule out the underlying abnormalities, and this can usually be done with a CBC, a CMP, and a urine tox screen. The differential is going to include the various causes of dementia, and that's usually indicated because they have a chronic history and no acute medical problems that are staring at you. Substance intoxication and withdrawal are also a cause of delirium, but it's something that you need to quickly notice that if it's there, because it's something that you can treat right away, especially if it's heroin. And so the urine tox screen and history will convey this. And then delirium tremens. These patients have a history of they'll have a history of alcoholism, and they'll also have hypertension and convulsions. Hypertension and convulsions aren't typical in the other causes of delirium. So the management for delirium is to correct the underlying medical condition, and it's supportive if the patient is intoxicated. If necessary, you can use Haldol or an atypical antipsychotic. In the event that the patient is agitated, they would definitely present a threat to themselves or to hospital staff. So now dementia, on the other hand, is chronic and progressive, and it's a disturbance in cognitive function, just like delirium, but it's chronic and progressive. And dementia is associated with actual progressive CNS damage. So there's various causes, and the onset is insidious. This isn't something that happened yesterday, or it happened while the patient was in the hospital. They weren't normal yesterday, and now they're demented today. This is something that's been going on for a long time, and now all of a sudden we're starting to notice the symptoms. So, as mentioned, it's a progressive state, and the disorientation is also progressive. So the patient will first, as the dementia starts, will be disoriented to time, and then to place, and then as we get into the late stages of the dementia, they'll start to be disoriented to person. And in some types of dementia, personality changes are also prominent. The diagnosis for dementia will be based on history and sometimes on labs. A lot of times, most of the times, the labs will help us exclude other types of cognitive processes that would affect the cognition. So we're going to want to get these labs to rule out those processes. But otherwise, the history is going to most help us with dementia. And there'll be other symptoms for the various types of dementia, and we'll go over what those distinguishing factors will be. The differential for dementia will be, of course, delirium, which has a more acute onset and it fluctuates. Hallucinations are also more prominent in delirium, but they can also be present in dementia. Normal aging is a big reason why older patients will come in. They're complaining because they're occasionally forgetful. That's normal as we get older. But what's not normal is to ever lose orientation to person, place, or time, or to hallucinate. So patients with normal aging, they'll never lose orientation to person, place, or time, and they'll never hallucinate unless they have a psychotic disorder. But occasional forgetfulness is normal. And then pseudodementia, which we'll talk about much later, is patients with depressive symptoms, but they're less likely to fabricate answers to questions, and they're more likely to talk about symptoms. Whereas on the other hand, patients with true dementia processes will fabricate answers to questions, and they're going to deny that they have dementia. They don't actually think that there's a problem with them. And the management for any kind of dementia is going to be based on the underlying process that's going on, which we usually diagnose with history and labs based on what we're suspecting is the process. So these are the types of dementia that we're going to talk about. As you can see, there's 9 of them. These are the major types of dementia. Alzheimer's and vascular dementia take up almost 80% of the different dementias. So those are going to be the most common ones that you see. Parkinson's disease, which the dementia is actually caused by Lewy bodies, that's another somewhat common one. And then the other 6 are pretty uncommon. Actually, I should say the other 5 dementias. Pseudodementia is common, but it's actually not technically a dementia. Pick's, Huntington's, Creutzfeldt-Jakob, AIDS, and Wilson syndrome are pretty uncommon to see, but they will come up on the USMLE. Just because they're uncommon in real life doesn't mean that they're not common to come up on the USMLE. So, like I mentioned, about 79%, almost 80% of dementia is caused by either Alzheimer's or vascular dementia. You can probably imagine that there are going to be patients who have Alzheimer's who also have risk factors and therefore probably symptoms for vascular dementia. So 10% of patients are actually going to have mixed Alzheimer's and vascular dementia. You're probably not going to be asked about that on the USMLE because it's just usually they'll usually just ask you about specific diagnostic types of dementia rather than mixed types. And then the other types make up the approximately other 10%. So we're first going to start out talking about Alzheimer's dementia. Alzheimer's is far and away the most common cause of dementia. It's way over half of patients presenting with dementia. And it's characterized by a chronic decline in MMSE score. So the patient slowly loses orientation, and it's very slow. So the thing about Alzheimer's is there's really no other symptoms. It's really just dementia. There's nothing really else going on. The patient, usually we can exclude what we're going to talk about next, which is vascular dementia, and we can usually exclude that because the patient is otherwise healthy. They're not hypertensive, they don't have hypercholesterolemia. They're generally a healthy patient, but they're starting to forget things as they get older, and they're forgetting things and losing orientation, and their cognitive processes are declining slowly but surely. The pathophysiology for Alzheimer's is cortical atrophy, a reduction in acetylcholine and norepinephrine synthesis, and a deposition of amyloid plaques. Obviously, we're not going to make any diagnosis based on those things because those are all things that you would see on necropsy. Most Alzheimer's patients are brought in by family members because, like we mentioned, any dementia patient won't see the problem wrong with themselves. They'll usually be brought in by family members. Physical will be unremarkable. If there's focal defects, you should generally consider a different diagnosis. And because we want to exclude other causes, we're going to want to get a CBC. That's going to help us exclude possible causes from infectious process. We're going to want to get a CMP. We're going to want to get a B12 and folate because there are processes that look like dementia, particularly Wernicke-Korsakoff Syndrome, that are caused by alcoholism. And so we want to check for B12 and folate levels to exclude that. We want to get thyroid function tests, and we want to get an RPR to exclude neurosyphilis. And definitely we're going to want to rule out depression to exclude pseudodementia. And the diagnosis will be of exclusion. The management for Alzheimer's is going to be palliative, and it's going to be aimed at reducing symptoms. We do have some agents out for Alzheimer's, most prominently the acetylcholine inhibitors, and those are donepezil and galantamine, which is actually a transdermal patch that administers the agent, which is a little more, rivastigmine is the patch that administers the agent. Galantamine is oral. They're both the same, essentially the same. They do the same thing. It's just different modes of administering the agent. So rivastigmine is a patch. Galantamine is oral. Donepezil is also oral, and Tacrin is really not used that often anymore. These improve the symptoms of Alzheimer's, but they don't shorten the course. Usually Alzheimer's is 8 years from clinical diagnosis until death. And antipsychotics are used for agitation if necessary. Risperidone, the atypical antipsychotic, and haloperidol, which is the typical antipsychotic. And assisted living arrangements will ultimately be needed in the later part of the course of Alzheimer's. So this is a brain on autopsy. The one on the right is advanced Alzheimer's, and what you can really see is a general cortical atrophy. This is taken at approximately the level of the temporal lobe. So you can see sort of the deeper fissures and reduced brain mass. And it's both white and gray matter. So vascular dementia is characterized by demented symptoms, but it's also got focal neurologic deficits, and there's usually a nonlinear course of progression. So why would there be focal neurologic deficits and a nonlinear course of progression? Well, it's because this patient is having multiple small strokes, and that's what's causing the focal neurologic symptoms, because the strokes are happening in different parts of the brain. And then it's a nonlinear course of progression because the small strokes happen at different times. So it's not a linear course. It's a nonlinear course of progression because you're having strokes at different times. Well, what causes strokes? Hypertension, hypercholesterolemia, smoking, diabetes. Those are all risk factors for strokes. And so what we do is we distinguish this from Alzheimer's by the presence of focal deficits. Patients with Alzheimer's are not going to have focal deficits unless they have a mixed Alzheimer's and vascular dementia, but you're not going to be asked about that on the USMLE. So we distinguish this from Alzheimer's by the presence of focal deficits. The most common ones you're going to see is dysarthria, dysphagia, any kind of hemiparesis, focal weakness, ataxia, gait disturbances, hyperreflexia, which shows upper motor neuron damage, and pseudobulbar palsy, which is actually an inappropriate random display of emotion, usually laughing or crying. All of these can be, except for probably pseudobulbar palsy, can be demonstrated on the physical neurological exam. In any case, you should get a CBC, CMP, B12 and folate, TFT, and RPR to rule out any other cause of neurologic process. And in these patients, we're going to get a CT or an MRI to look for where the specific neurologic deficits are. So we definitely want to get neuroimaging. And so the diagnosing will be by normal labs and neuroimaging, which should show focal infarcts. And the management is really just to reduce the risk factors for having any further infarcts. So if the patient has hypertension, we're going to consider starting on an ACE inhibitor or a beta blocker or both if we haven't yet used those agents in the patient. And hypercholesterolemia, which we manage by diet, and almost certainly we're going to start this patient on a statin because they are having major complications from their high cholesterol. And of course, smoking cessation is always a good thing in any patient, and diabetes management. So here's vascular dementia. As you can see, there's no generalized cortical atrophy here. The brain looks pretty good, except that it's got some infarcts. And you can see right here we've got these white areas of the brain, and that is these are infarcts, and they're both at the gray matter and the white matter. Okay, so Parkinson's disease or Lewy body dementia. So Parkinson's disease is actually the disease process of Parkinson's, which doesn't always include dementia. So someone like Michael J. Fox does not appear demented. He appears fine. So he's got Parkinson's disease. When a Parkinson's patient starts to develop dementia, then we call that actual dementia Lewy body dementia. So Parkinson's disease that has dementia, or Lewy body dementia, is characterized by dementia in a patient with Parkinson's disease. It, of course, can be mixed with Alzheimer's dementia, but you're probably not going to be asked that on the exam. There are going to be no focal symptoms in these patients, apart from those that we would expect in patients with Parkinson's disease. So just to recap, what is Parkinson's disease? You're going to see resting tremor. So these patients aren't going to be tremulous when they're walking. They're going to be tremulous when they're sitting down. They'll have a pill rolling tremor, and what that is if you can imagine taking a small ball like a marble and rolling it around in your hand with your thumb. That's what these patients actually do, and they have nothing in their hand, but that's a tremor that they have. Bradykinesia, which is a slow movement, shuffling gait, which, I mean, you'd have to look these things up on YouTube. I can't really show you, but it's sort of a gait where they're not picking their feet fully up off the ground. Masked faces, where they don't show any marked expression on their face. Micrographia, which is a small handwriting. You'll probably be told these things on the USMLE. These aren't necessarily things you see clinically, but these are things to keep an eye out for on the stem of the question. And then another thing that you'll see is cogwheel rigidity, which I didn't put that on there, but that's something very characteristic of Parkinson's disease. And the pathophysiology of Parkinson's disease is a destruction of the dopaminergic neurons of the substantia nigra. And the dementia is caused by Lewy bodies. We don't get brain biopsies in these patients, so knowing what Lewy bodies look like is not important. I have never seen a biopsy question, or actually a biopsy picture on the USMLE step 2 or 3. So know what Lewy bodies are and what they're associated with, but you don't need to know what they look like. That's a USMLE step 1 question. The diagnosis for this type of dementia is clinical, and it's based on the patient's history of Parkinson's disease. Labs are generally not necessary. When a patient comes in with dementia and they have diagnosed Parkinson's disease, we can safely presume that the diagnosis is Lewy body dementia. And the management is going to be the same as management of Parkinson's disease. there's really no treatment for the dementia. And so the management for Parkinson's disease, just as a review, we're getting a little bit of neurology here, is replacement of dopamine, and that's done with carbidopa-levodopa. And what that does is it helps, because you can't just administer dopamine can't cross the blood-brain barrier. So the synergy of carbidopa-levodopa helps the dopamine precursor cross the blood-brain barrier. Dopaminergic agonists are also given, and that increase the quote-unquote activity of dopamine. Obviously, these things aren't dopamine, but they simulate dopamine. So that's benztropine, pramipexole, and ropinirole. Remember that pramipexole has a very unique side effect of compulsive gambling. It's not common, but when you hear about compulsive gambling developing all of a sudden and the patient is on, if the patient has Parkinson's disease, pramipexole should be front of your mind. And MAO-B inhibitors also are given for Parkinson's disease. MAO-B inhibitors are given for depression because they reduce the breakdown of dopamine. But in Parkinson's, they're given because for the same reason, because dopamine is at a severe deficiency because of the degenerative process. So selegiline is the MAO-B inhibitor of choice. So these 5 drugs are the most commonly given, and they're our first line of choice, with carbidopa and levodopa being probably the most prominent. Amantadine can also be given as conjunctive therapy. It's definitely not a first choice. Amantadine is an antiviral, but it's very commonly given in Parkinson's disease. Okay, so Pick's disease. Pick's disease is a frontotemporal dementia. So it's very difficult to distinguish Pick's disease from Alzheimer's in a clinical setting. But on the USMLE, when they want you to diagnose Pick's disease, what they're going to tell you is that the patient had personality changes prior to the onset of the Alzheimer's-like symptoms, prior to the onset of memory changes. So personality changes is very key for diagnosing Pick's disease. So like I said, it's difficult to distinguish Alzheimer's from Pick's disease. So the personality changes is what needs to be forefront of your mind. If you see that, Pick's disease should be something that you think about. And you should always get CBC, CMP, B12 folate, TFT, and RPR on any patient that has Alzheimer's-like symptoms. And the diagnosis is clinical and by exclusion. Management is going to be palliative. Unfortunately, the medications for Alzheimer's are generally not effective in patients with Pick's disease, and so we're going to palliate these patients. Huntington's disease is characterized by a progressive dementia, but it's also accompanied by chorioathetosis, which is a movement disorder, and personality changes. Psychosis and suicidal thoughts are also common. So this is a genetic disease. So at some point, the patient or the patient's family member is going to tell you that they have a parent who is affected. Because it's autosomal dominant, the patient must have inherited it from a parent, and that parent had to be affected because it's dominant. And so the pathophysiology here is going to be an atrophy of the caudate nucleus. And remember, the caudate nucleus is responsible for, along with the frontal lobe, it's responsible for personality, it's responsible for learning. So the changes in these patients are going to be primarily personality changes at first, before the dementia. The caudate nucleus is also important for movement. So that's why we're going to see the chorioathetosis. And the differential here includes schizophrenia. Anytime you have psychosis, the number one thing you're going to think of is going to be schizophrenia. But obviously patients with schizophrenia aren't going to have a family history of Huntington's disease. They're not going to have chorioathetosis, whereas the patients with Huntington's disease will. Diagnosis is going to be based on family history. It's going to be on genetic study. And There'll also be some clues with the CT, which will show mildly enlarged ventricles. And what that is due to caudate degeneration. The caudate borders the lateral ventricles. So, of course, as they degenerate, you're going to have more space for the ventricles, and they're going to appear enlarged. But it's not hydrocephalus. You're not having actual enlargement of the ventricles. It's just due to brain matter around the ventricles degenerating and causing the ventricles to therefore get bigger. The management for Huntington's disease is also palliative, and we emphasize treating the depressive symptoms and definitely treating the psychotic symptoms, and we do that with SSRIs and with antipsychotics. Actually, this is wrong. I wanted to show you something else here, but this is for the next thing. Sorry about that. So Creutzfeldt-Jakob disease. I'll add this at the end. So Creutzfeldt-Jakob disease is a rapidly progressive dementia, and that is key with Creutzfeldt-Jakob disease. So if anytime you get a USMLE question on Creutzfeldt-Jakob disease, it's going to say 10 months ago the patient was fine, and they've been quickly developing these symptoms of forgetfulness, of inability to remember objects, of inability to perform activities of daily life. And so it's going to resemble Alzheimer's, but it's like compressing Alzheimer's into like a 1-year period as opposed to a 10-year period. It's also going to have some resemblance to Huntington's disease in that there is actually gait disturbances and chorea. But the most distinguishing factor about Creutzfeldt-Jakob disease is that it is fast. The onset to death from diagnosis and onset of symptoms is within months. So the autopsy is going to reveal spongiform encephalopathy. And that's what's actually most key, because you're going to be told this in a lot of cases on the USMLE. So you probably remember this from USMLE Step 1 and seeing the spongiform encephalopathy. Sometimes they'll tell you that on Step 2, or sometimes they'll just tell you that it's rapidly progressing. In a lot of cases with Creutzfeldt-Jakob disease, it's an infectious disease. So it's transmitted by prions. And how is it infectious, and why is it rare? Well, it's infectious because it's in prions, and it's rare because really the only way to get it is by consumption of brain material. And so we don't see this at least in the United States, very often. You do actually see it in Papua New Guinea, and that's because they, in that culture, have had a history of cannibalism, and they do consume brain parts, which is actually the cause of something called kuru, but we're not going to talk about that. But keep in mind that Creutzfeldt-Jakob disease can be transmitted by consumption of affected brain parts. In any patient you suspect Creutzfeldt-Jakob disease, you should definitely get an EEG. So if this crosses your mind, even though it's rare, if it crosses your mind, an EEG is the next step. And what you'll see characteristic of Creutzfeldt-Jakob disease on an EEG is sharp triphasic synchronous discharges. So if you have that, in addition to the clinical symptoms, which is a rapidly progressive dementia, then this will be diagnostic. But most of the time on the USMLE, what you're going to see is a patient that has rapidly progressive dementia. They were fine a year ago, 9 months ago you started getting changes, and now all of a sudden they're practically incapacitated. That's Creutzfeldt-Jakob disease, and the management is palliative. Okay, so let's go back here. I need to fix this. So this is Creutzfeldt-Jakob disease. Ignore what's on the top. This is Creutzfeldt-Jakob disease, and what you see here is a brain biopsy. And these little white spots, bigger white spots, these are the spongiform changes. So you shouldn't see that on normal brain biopsy. They're not going to give you a biopsy on Step 2 or Step 3. What they're going to tell you is spongiform encephalopathy. And ignore what's on the top again, sorry. This right here is Huntington's disease. And so what you have there, if you see that gray matter that borders the lateral ventricles, so here's the lateral ventricles in the control. This is a normal patient. And this is gray matter here. This is the caudate right here. And so what you have here in the control is a normal caudate. Look what's here in this patient with Huntington's disease. You don't see hardly any of that caudate that exists in the patient, in the control patient. You see the rest of that gray matter, but you don't see any caudate. And that's what causes the enlarged ventricles. Okay? Sorry I screwed that up here. Okay, so AIDS dementia complex. So almost all the time in the USMLE, they're going to give you a patient that's having symptoms of dementia, and they're going to tell you that the patient is also HIV positive. That should be a dead giveaway. But you're going to want to look at what the symptoms are in these patients, especially if you're on the clinical wards, because you'll see some different symptoms than just dementia. So in patients with AIDS dementia complex, you're going to see dementia and focal neurologic symptoms. Now, what should be the first thing you think of when you see a patient with dementia and focal neurologic symptoms? It should be that this patient has vascular dementia. But in a patient with a confirmed HIV infection, you're going to want to rule out AIDS dementia complex. And in most patients, unlike in vascular dementia, in most patients with AIDS dementia complex, they're going to have mood and personality changes that precede the dementia. And the most common focal deficits that the patient has, focal neurologic deficits that accompany the dementia, are going to be hypertonia and hyperreflexia. And a lot of times you'll see the snout reflex, which is where you brush the top of their nose and they make that kind of snouty face that babies make. If you look that up on YouTube, just type in snout reflex, you can see what it looks like. What all of these are a sign of is upper motor neuron damage. And so the mood and personality change that precedes the dementia is going to be what sets apart AIDS dementia complex from vascular dementia. Okay, so they both have focal neurologic symptoms, but unlike vascular dementia, you're going to see mood and personality changes before the dementia. And you see mood and personality changes in Pick's dementia, but unlike Pick's dementia, AIDS dementia complex won't have focal neurologic symptoms. So it's AIDS dementia complex is like if you took Pick's dementia and if you took vascular dementia and combined them into one in a patient that's HIV positive. So that's a good way to think about it. Definitely consider AIDS dementia complex in any patient that presents with HIV and psychotic symptoms. Some of the mood personality changes, they can actually be psychotic symptoms. So if a patient has HIV and they present with psychotic symptoms, definitely consider AIDS dementia complex. These will generally be patients that have very poorly controlled HIV, they've got low CD4 counts, they've got high viral loads, and so the management is to prevent progression by getting these patients on an adherence to a highly effective therapy, which is usually HAART. So we usually make sure that they're on 2 or 3 antiretrovirals. Okay, Wilson's disease is very uncommon, and it's characterized by an executive dementia, which is accompanied by psychotic disturbances, movement disorder, and prominent liver function. Prominent liver dysfunction, I should say. So most of the time, patients with Wilson's disease aren't going to actually present with dementia. They're usually going to present with the psychotic symptoms or fatigue. And what is the fatigue from? The fatigue is from liver dysfunction. So Wilson's disease is autosomal recessive, and it's a disorder of copper metabolism. And what it actually is it's a defect in ceruloplasmin, which is a binding protein for copper. And so why is that a problem? Well, if you don't bind copper, copper is free in your blood, and then copper is free to get into your eyes and get into your liver and get into different organs and ultimately cause inflammation and of course into your brain too, and cause inflammation and dysfunction. So it's a multisystemic disorder. Usually dementia is not the presenting symptom, but if you do, it'll be an executive dementia. It's not going to be disorientation. It's usually going to be an inability to function in daily life, like inability to keep lists, inability to hold a job, etc. Usually with Wilson's disease, the presenting symptom is going to be upper right quadrant pain. It might be psychotic disturbances similar to schizophrenia. And so the diagnosis for Wilson's disease, you're going to have a patient that's got very elevated LFTs. The patient is often going to have the presence of psychosis, and they'll uniformly have high urinary copper. These patients can't bind their copper because they don't have ceruloplasmin, so their copper is free and it gets filtered through their kidneys and they urinate it out. Kaiser-Fleischer rings are pathognomonic for Wilson's disease. So if you see a picture of a Kaiser-Fleischer ring, as I'm sure you remember from step 1, immediately Wilson's disease is going to be what you think of. The diagnosis is confirmed by the presence of low ceruloplasmin level. And of course, anytime a patient has psychotic symptoms, you're going to want to differentiate schizophrenia. And schizophrenia patients are going to have normal LFTs in most cases, and definitely they're going to have a normal urinary copper. The management for Wilson's disease is to chelate out the copper that's free, and that's done by IV penicillamine. And then we're going to want to make sure that they don't have high copper again, so we're going to keep their copper diet low, and that's done by avoidance of nuts, shellfish, mushrooms, dried fruit, and other high copper foods. So IV penicillamine and a low copper diet. This is a Kaiser-Fleischer ring. So the arrows show that brownish ring. This patient has bluish-green eyes normally, but that brown ring that's around their iris is the Kaiser-Fleischer ring. And all this is a deposition of copper in the Day-Cement membrane. Pseudodementia. Okay, so this is not dementia. This is symptoms that look like dementia. And we always have to exclude this when an elderly patient presents with any symptoms of dementia. So this is the old lady that comes in. Her husband died last year or 6 months ago or last month, and she is worried because she can't remember things, and sometimes she might be disoriented. What's most important here is that you identify depressive symptoms or any kind of risk factors for depression. So if they've had a recent loss, if they are living by themselves, these are all risk factors for depression. So we want to make sure that we rule out depression when a patient has pseudodementia, when a patient has symptoms of dementia. A lot of times, the USMLE is going to give you clues of pseudodementia. What are those clues? First off, when you give the MMSE, or when you ask for a history, the patient with pseudodementia is going to reply, "I don't know," or I can't remember, to the question. So if you ask a patient, for instance, who's the president of the United States, they're going to say, "I don't know." Whereas a patient with true dementia is going to confabulate. So they might say Ronald Reagan, or they might say Jimmy Buffett. They're going to try to give an answer. Patients with pseudodementia aren't even going to try. They're going to be withdrawn. Also, a patient with pseudodementia is going to be able to state the approximate onset of the symptoms. Whereas a patient with actual dementia, they're not even going to remember. So they'll say, "I don't know." And more than that, patients with actual dementia, they're going to think they're fine anyway. So they're going to deny they even have symptoms. Whereas a patient with pseudodementia, a lot of times they'll bring themselves in. So those are ways we can exclude dementia from pseudodementia. Diagnosis is going to be clinical, and the management is going to be the same way we would diagnose, or the same way we would treat depression or major depressive disorder, which is SSRIs and psychotherapy.
So we'll move on here to Wernicke-Korsakoff Syndrome. This is an amnestic disorder. And really this is two disorders, but they're caused by the same thing. So they're both caused by thiamine deficiency. And in particular, we see this in alcoholics. Now, there's nothing about alcohol that's actually going to cause you to be thiamine deficient. The fact is that patients who are alcoholics chronic alcoholics have a tendency to be thiamine deficient because they're malnourished. So you can see this in other people, but classically we see this in alcoholics. Wernicke encephalopathy and Korsakoff psychosis are two different syndromes. Theoretically, you can have one or the other, but many patients will present with both of these at the same time. Wernicke's encephalopathy is a neurologic disorder. It's comprised of gait disturbances as well as ocular motor symptoms. So you'll see ataxia, and then nystagmus and ophthalmoplegia. Korsakoff psychosis is a more of a psychiatric amnestic problem. They'll look a lot like patients with Alzheimer's. However, they have this tendency to confabulate, and their memory issues are more related to short-term things. So you may see a patient in the hospital, you go in and see them 2 hours later, and they won't remember that you had been in there. So these confabulations are interesting. They will have a tendency to make up memories. So they forget, and then they will they'll substitute in things that never happened in to make it look like they didn't forget it, and they don't realize they're doing this. These are confabulations, and it's not necessarily specific, but it's somewhat characteristic of Korsakoff psychosis. So a good way to remember wobbly Wernicke's, crazy Korsakoffs being neurologic and psychiatric. So as I mentioned, this is due to low levels of thiamine, usually related to chronic alcohol consumption. Diagnosis is based on history and a low thiamine level. Now, anytime you have a patient who's an alcoholic coming in with any problem at all, it's important to get a thiamine and folate level, because these patients have a tendency to be depleted in this regard. And certainly if you have any neurologic symptoms or psychiatric symptoms in a patient with alcoholism, good to get levels on these as well. Now, why does this become very important? It becomes important because when you are managing an alcoholic patient, a chronic alcoholic patient in the hospital, you need to be aware if they're vitamin deficient. So for instance, if a patient is thiamine deficient, you need to replace that thiamine right away. A patient could be thiamine and folate deficient, and if you replace the folate before you replace the thiamine, or you don't replace the thiamine at all and you give the patient dextrose, basically if you do anything other than giving the patient IV thiamine first, replacing the thiamine, you can precipitate something called subacute combined degeneration, which is a myelopathic disorder of the spinal cord, and that can lead to serious sequelae down the road. So if you ever administer IV dextrose, make sure that it is supplemented with thiamine in any patient where there is known or suspected history of alcoholism. On the wards, we have what's called banana bags, and these are just they're just IV formulations that have your dextrose, IV fluids, and then a bunch of different vitamins. It's better to lean towards that if you're dealing with a patient that's either severely malnourished or alcoholic, than to just give dextrose and normal saline. Because if you're providing, it's difficult when you're talking about B1 and B12 and folate. It's hard to give a patient too much of that. However, if you replace sugars, if you replace folate and you don't replace the thiamine, you can precipitate subacute combined degeneration, and you definitely don't want to do that. So you have a patient with a known history of alcoholism, even suspected history of alcoholism, lean towards giving the vitamins along with the replacement fluids and the dextrose.
And so here's a review of the different types of dementia. So what I put here are the different types of dementia and pseudodementia, and the causes, the distinguishing features that you want to keep an eye out for, that you're going to see in the stem of the question on the USMLE, and then the treatment. So Alzheimer's, the cause is amyloid plaques. There are no distinguishing features of Alzheimer's. It's just a chronic linear dementia, and the treatment is with our acetylcholinesterase inhibitors, donepezil, galantamine, ribostigmine, etc. Vascular dementia is caused by multiple infarcts. It's diagnosed on CT or MRI. The distinguishing features are going to be focal symptoms, hypercholesterolemia, diabetes mellitus, hypertension, and the treatment is going to be diet modifications, ACE inhibitors, beta blockers, statins, diabetic management. So hyperresonance on your MRI or CT are going to be key for diagnosing vascular dementia. Parkinson's dementia or Lewy body dementia, the cause is Lewy bodies. We're not going to see those clinically, and so we diagnose this based on the fact that the patient has movement symptoms, diagnose Parkinson's disease, and they also have dementia. The treatment for this is going to be the treatment for Parkinson's disease, which is carbidopa, levodopa, and the dopamine agonists, as well as amantadine, which is our second-line therapy. Pick's disease is caused by frontotemporal atrophy. The distinguishing features here are going to be personality changes that precede the dementia, and the treatment is going to be palliative, no therapy for Pick's disease. Huntington's disease, the cause is caudate degeneration. The distinguishing features is going to be a family history, and you'll see large lateral ventricles if you do a CT. Treatment here is also palliative. Creutzfeldt-Jakob disease is caused by a prion. The distinguishing factors is a rapid onset, generally within months, and then in Creutzfeldt-Jakob disease, you're also going to see the EEG, synchronous sharp triphasic discharges. The treatment here will be palliative. This is quickly progressing. AIDS complex dementia, the cause is actually the AIDS or the HIV virus. That is the actual cause. So this is not a opportunistic infection. The actual cause is the HIV virus itself. And the distinguishing factors here are going to be that the patient is HIV positive. They're going to have personality changes that precede the dementia like Pick's, and they're going to have focal neurologic symptoms like vascular, and they're also going to have upper motor neuron symptoms most prominently. And the treatment here is to make sure that the patient is compliant with their heart therapy. Wilson's disease, the cause is a ceruloplasmin deficiency, which is autosomal recessive. The distinguishing factors here are going to be that the patient has prominent liver function test abnormalities, and a lot of times the patient is going to have Kaiser-Fleischer rings. And the treatment is penicillamine and a low copper diet. Pseudodementia, the cause is actually depression. This is not real dementia. The distinguishing features here are going to be that the patient will often say that they don't know, they're not going to confabulate like most patients with dementia, and they're going to appear depressed and have a lot of the CDCAP symptoms. If not, they'll actually have the criteria for major depressive syndrome or major depressive disorder. And the treatment here is going to be with SSRIs and psychotherapy as we would treat major depressive disorder. And this is kind of just lighthearted. This is a picture of myself in Boston at the Sam Adams Brewery, which I have to say is probably one of the best brewery tours I've ever been on. So definitely recommended if you are in the Boston, New England area. So with that, we will talk in the next section.